Our Chief of Staff from Red Cross, Selena Rodan.
I just really quickly wanted to welcome all of you here. Please consider this a home. Please, hopefully this will be the first of many other meetings that you'll have, many other conversations. For those of you that don't know, our region of the Red Cross is one of the largest regions in the country. We cover 21 counties in northern Illinois, but 70% of the work that we do is in and around Cook County. It's also important that I tell people this all the time, that the number one disasters that the Red Cross actually responds to nationwide is fires. So in and around our region, we respond to 4 to 5 home fires every single day. Every single day I get a report telling me the fires that we've responded to, and the majority of them are happening in and around Cook County. We're also responsible for 40% of the nation's blood supply. This summer, we had a blood shortage. There were points during the summer that we had less than a 5-day supply of blood on hand, which was at a critical level. So these are all really important issues that are impacting us and our work and our community, and so we look forward to having more conversations with all of you, hopefully more partnerships and dialogue to help us to be able to do our work, and we'd love to have your help and support in doing that.
Thank you. The Illinois Medical District, which is where we're in now. Funny thing is, I actually grew up around this area, so I've seen how much it's changed. But of course, this would not have happened if it wasn't for a good partnership through Brian Cage, the Director of Communication. But before we get started, I wanted to make sure that I allowed IMD, Medical Commission, to come up and give us a couple words.
Good evening, everyone. As Stephen said, I am Kate Schellinger. I'm Chief of Staff at the Illinois Medical District, which, as he mentioned, we are sitting within the borders of the Medical District. It's an area of the city that stretches from Ashland on the east to Oakley on the west, 290 down to 15th Street. And it's a 24/7, 365 environment that includes medical research facilities, labs, biotech business incubator, universities, more than 40 healthcare related facilities, and of course 4 major hospitals that we have here in the city. So that's just a little bit of background on what is the IMD, because we get that question a lot. Thank you very much again to Stephen for the opportunity to partner with the MetroBoard for this event. We're very excited, and I'd also like to thank the Red Cross and Selena for the space. It's a beautiful building that we're very thankful that they donated for the event. Now I'd like to introduce to everyone our moderator tonight, who is Dr. Cameron Matthews. Dr. Matthews joins us from the University of Illinois Hospital and Health Sciences System, where she is the Chief Medical Officer of Miles Square Health Center. She previously served as Site Medical Director of the Division Street site of Erie Family Health Center, which is another federally qualified health center in the city. Prior to that, she worked for 2 years as a staff attending physician at Cermak Health Services of Cook County, which is the entity that provides health care to the detainees of the Cook County Department of Corrections. As a passion outside of her clinical and administrative roles, she is proud to co-direct the Tour for Diversity in Medicine, which is an initiative seeking to bring pre-medical enrichment activities to minority high school and undergraduate students across the country. She also serves on the board of directors for Polaris Charter Academy, learning charter school in the Humboldt Park neighborhood of the city, and she is a lead analyst for Policy Prescriptions, which is an evidence-based health policy website.
Again, my name's Cameron Matthews. I am a very proud family physician, which is a field of primary care that I think is, well, I'm not going to get on my soapbox, but primary care in and of itself is a whole nother topic of discussion series as it is. But in that, I think I wanted to just give a little bit of framing for the evening before I introduce our panelists, as far as just kind of the status of affairs as far as health disparities. We're here to discuss health. We're here to discuss, hopefully, how we can come up with some solutions to really better our communities and the patients that we serve and the people that we teach and reach on a daily basis. But it's good to have an understanding of kind of where we're coming from as far as a baseline. You guys remember, I remember the night, actually I was still a resident when the Affordable Care Act was passed. This was in 2010, right? I stayed up all night, the true politico geek that I am, and watched all the votes roll through on C-SPAN. And you know, over time, there was a lot more conversation, I would say probably a little late in the game, about what the Affordable Care Act is. And when I say late in the game, most physicians were still asking, what is this thing after it got passed? Just because a lot of us, particularly those of us that look like us in the room, weren't necessarily at the table in creating it. But since then, we do have a lot of great data out there about what it's been able to do. And one of the things that I'm proud of as a primary care physician is that it really has addressed a lot of the needs that we face at Miles Square and other community health centers as far as providing somewhat more access to our patients to be able to access the system. However, we do know, and Kaiser Family Foundation, a lot of different groups that are studying the ACA and its after effects, are actually still showing that disparities are persisting regardless of how we're funding them, okay? So the Affordable Care Act was really something more about financing, giving you insurance, but that doesn't mean you still have access. That doesn't mean people are treating you fairly when you're walking into the emergency room. That doesn't mean that we're actually making better outcomes for our patients, for our communities, for our family members. And it's been shown time and time again, unfortunately, based on race and ethnicity, African Americans, Latinos, Native Americans, we have worse outcomes. And that's one thing that unfortunately the Affordable Care Act has not been able to improve in the short amount of time that it's been in existence. But it has improved other things, and we may get to that a little bit. But I think knowing that disparities exist is one thing, but then knowing why they exist is a different conversation, and hopefully we'll get into that as well. Hopefully we'll get into this concept of social determinants of health as well. If you haven't heard that phrase, it's really the concept that there are other factors in your life that affect your healthcare, as opposed to just who your doctor is and things. It's your education level, it's how much money you make, it's how much you understand what your doctor is telling you. It's whether you're working or not. It's actually whether your parents worked. I mean, there's so many different facets in it, but that is posited as one of the major reasons why our communities are affected with these disparities. Of course, there's racism and there's other things that we should be talking about as well too. But that I just wanted to kind of provide as a framework that we're in kind of this new world. Everyone, at least in my world, I don't know if everybody's world, we're talking about the ACA and how it was supposed to be the solution. But really it's actually exposing a great deal of more issues and that I see on a daily basis in primary care. But we can definitely talk about that. Their photos are here, but let me start with my friend Ingrid here. Dr. Ingrid Burnett Ziegler is a licensed clinical psychologist and assistant professor in the Department of Psychiatry and Behavioral Sciences at the Feinberg School of Medicine at Northwestern University. She's also the founder of Becoming One Wellness, LLC, which provides education, training, and consultation to individuals and organizations looking for ways to manage stress, improve functioning, and wellness. She received her undergraduate degree in psychology from Cornell University, her doctorate in clinical psychology from Northwestern University, and completed a postdoctoral fellowship in mental illness research and treatment at the University of Michigan. I'm trying to cut, but at the same time, I want to give like your pages of bios here. But no, Ingrid is amazing and is going to give us a lot of insights, particularly when we're talking. And thank you guys for filling out the surveys with your registration, particularly when we're talking about behavioral health issues, because that's actually one huge area of concern for our communities that we tend not to address in these open forums. Thomas Fisher is a board-certified emergency medicine physician, and health policy leader. He is senior advisor and executive vice president of health services at Next Level Health and an attending physician at the University of Chicago Medical Center. Previously, he served as vice president of health delivery transformation at Healthcare Service Corporation, where he developed innovative healthcare solutions that led to the delivery of high-value care for Blue Cross and Blue Shield members in 5 states. Prior to joining HCSC, Dr. Fisher was a White House Fellow at the United States Department of Health and Human Services, where he worked on Affordable Care Act regulations, including Medicare Share Savings Program and Pioneer ACOs. He also led the development of the HHS Action Plan for reducing racial and ethnic health disparities. Friend here, Adrian Boscolo Hightower. We are so happy to have him as a third-year medical student. So really the future of our field here. He's a third-year medical student at the University of Illinois at Chicago here in the IMD. He graduated from Stanford University with a BA in Human Biology and an MA in Sociology with a concentration in social stratification and inequality. After graduation, he served as a project officer at the Department of Human and Health Services Office of Minority Health, where he oversaw grant programs that targeted youth violence prevention and health disparities initiatives throughout the state of Mississippi. Most recently, he worked as a clinical research associate at Seattle Children's Hospital Center for Diversity and Health Equality. where he published research on improving rates of medical interpretation and assisted in the development, implementation, and evaluation of programs that improved access and delivery of care to patients from different racial, ethnic, socioeconomic, and language groups. Jamil Abdur-Rahman, a licensed private pilot. I love your bio. U.S. Army Medical Corps veteran and board-certified obstetrician and gynecologist, more affectionately known to his patients and friends as Dr. J. Dr. J is the older of twin brothers by 7 full minutes. I know every minute counted. And this is something he never lets his younger brother forget, who Idris Abdur-Rahman, or Dr. I. So Dr. I and Dr. J, I love it. They both grew up here on the South Side in a single-parent household and completed their undergraduate and graduate studies at University of Illinois and Chicago's Rush Medical College, also here in the IMD. So all of us are kind of homegrown. He completed his postgraduate residency training in OB-GYN at Mount Sinai here. And he and his wife Ruby, who's also in healthcare, a labor delivery nurse, have 3 children, 2 sons and 1 daughter. He's a passionate medical and travel blogger. He's been on The Doctors. He's been on multiple television programs. We can go on and on. You are an impressive man. And we are happy if you guys could go into how I went into a little bit primary care and disparities and really more social determinants of health, how they're affecting my patients. But I was wondering if we could just kind of do a round table on how disparities are affecting what you're doing, or at least how you feel what you're doing are actually going to impact disparities on top of that. Actually, I think that's probably a more poignant point.
I wear 2 hats largely. One is as a clinician, I take care of people in the emergency department. And I chose the emergency department because when I started training, that was the only place in the healthcare system where people could receive care regardless of their ability to pay by law. And so it was there that you saw a cross-section of society. You saw the rich, the poor, you saw the homeless, you saw the deans of the medical center, you saw everybody. That part hasn't changed, but regularly what I saw were people who were trapped by the healthcare system, and it was that led them to the emergency department. Things like the inability to fill prescriptions, to make it to their appointments because clinics close during business hours when people have to work. Challenging choices between caring for their family members and caring for themselves. Largely, the category of social determinants, which I always truncate into how you live, learn, work, and play, lead people to health and illness. And all of those things manifest in the emergency department. But I regularly became frustrated with my inability to use prescriptions and procedures to improve people's status. And so I worked on policy and trying to reshape a healthcare system towards one that is more responsive. That led me through academia, through government, into the payer side, where you're creating incentives that direct how people receive care. And what I try to do is bring the lessons of the laboratory. So what happens when I'm taking care of a patient, the challenges that people are facing, the obstacles that create time hurdles, that extend waiting times, that extend hospitalizations, that cause people to rebound into the emergency department after they've been admitted, and translate that into actually the delivery of care through the lens of a healthcare product. How do you align the incentives so that everybody is, from the insurer to the doctor to the community health worker to the family members, are all similarly invested in keeping that individual healthy? I'm not going to say we have the solution, and in fact, I suspect we won't see the solution in my professional career. However, if we can begin to put in place things like value-based insurance designs and bundles of care and align groups of providers like primary care docs and specialists and community health workers and social workers and nurses in these in new teams of care, then I feel like I would have contributed something. So given the 2 spheres in which I work, that's my intent.
And for me, it's a little bit interesting because since I'm at the bottom of the totem pole, I like to say a lot of times, it's difficult to think about what actions can I take now to kind of make sure that the message is being spread about addressing health disparities. I think as students, it's very easy to kind of get lost. We're kind of in school and we're learning all this information and we have to pass all these exams, but at the same time, we want to make an impact. And those are the reasons why we came to medical school. One of the reasons why what drove me to become a physician was because I knew that there was real issues and there was this this inequitable care that was being distributed from different populations that was based on socioeconomic status, race, and different things. So how can we do something about that? So did a lot of work before coming to medical school, and now you get to medical school, how can this continue? And so there's a lot of things you can do. I mean, there's things that we do, part of the Student National Medical Association, which is like the best way to compare it is like the NAACP version of like medical school. And so, so we do like different outreach projects, do different health fairs and things like that, but sometimes you feel like that's not enough, right? Like just going and taking a blood pressure and telling somebody like, hey, you have high blood pressure, and we still try to connect them with resources, but that's not enough. So a group of us, what we did is we got together and think about how can we affect medical education for the future to make sure that we're not just preaching to the choir. Because all too often we have people who come to these rooms and want to hear this message are people who already care and are interested in the issues. So what we really thought about is how do we get folks who don't think about disparities on a regular basis or health equity on a regular basis to think about these issues. So there's a group of us who interact with the Sickle Cell Center at UIC. UIC has one of the largest sickle cell centers in the entire region, and they have a patient support group. So what we did is we really thought about incorporating the idea of or specifically the idea of sickle cell and the disparities related there into like the actual medical education program that we have itself. So we have small groups, we have different things that people get tested on and different things, because we know if it's going to be on a test, people are going to study for it and they're going to think about it, right? So what we did is try to work with the course professors and different leadership in terms of the curriculum amongst the school to really start to have a small group session that talked about health disparities, not just the actual science part of it, but the psychosocial in terms of when you have a patient who comes into the ED and they're in pain and they're asked for a certain amount of drugs, but they don't get it and the physician thinks that they're just there for drug-seeking behavior. Like, what are those things? So really bringing these ideas of equity and health disparities to the classroom and to the curriculum such that everybody has to think critically about these issues and start a conversation there. So we give those people the tools in the future, and when they become physicians in whatever field, whether it's orthopedics or surgery, to know that, you know, I thought about this and I know that I just can't immediately go to my biases right now. I have to think about critically about this issue. So from a student perspective, that's what we tried to do, really kind of close that gap, or a little bit at least, to try to talk about all the issues that we talk about in closed rooms and amongst our friends sometimes, but really spread that to people who are going to be physicians of the future, and all of them, not just the people who look like us.
My perspective is maybe a little bit different from the perspective you guys have as an OBGYN, and that's because even before the ACA, and certainly after the ACA, women and children, to an extent, have always been valued. And so you always, for the most part, have coverage. So I haven't really run into situations. Now, I do sometimes when I have a patient come into the ER, for example, about follow-up and things like that, and prescribing medications and can it be filled. But by and large, when it comes to issues of coverage, women and children are covered. And so I haven't encountered too many situations where people aren't covered. But I do still see healthcare disparities manifested in a different way. So it's not so much a matter of coverage. It's more a matter of the outcomes that people have and the psychosocial issues that they bring to their healthcare. So it goes without saying that for the most part, Black and brown people, I don't care what healthcare metric you use, in OBGYN or anything else, but I can tell you more about OBGYN, they're pretty much always at the back of the line. And it can sometimes be an issue of coverage, but it's less an issue of coverage and more an issue of how the resources that are potentially available are used. It's also a matter of the psychosocial issues that people may bring to the healthcare process to begin with. And so my perspective is one that isn't focused so much on ensuring that the care is available to people. It's more a matter of ensuring that the care that's available is utilized. And more important even still, maybe modifying some of the psychosocial factors that lead to the issues that ultimately need to be addressed.
In my role at Northwestern, I provide clinical care to primarily adult women with mood and anxiety disorders, so things like depression, bipolar, generalized anxiety, and provide therapy to those individuals. As well, in the majority of my role, I conduct research, and my research is focused on better understanding factors that predict access and engagement in mental health service utilization. So I spent a lot of time really trying to understand the predictors, like the demographic characteristics, the socio and economic characteristics that predict mental health service utilization. So just as a point of information, about a third of individuals in the general population will experience a psychiatric condition at some point in their lifetime, and less than half of those will make contact with the mental health service system. And racial and ethnic minorities are even less likely to contact the mental health service system. So I was really interested in understanding why that might be. Some of the things related to that are, as you might guess, negative attitudes around mental health treatment, things like identifying yourself or screening around mental health treatment, what it means to have a psychiatric disorder, what it means to be in treatment for a psychiatric disorder, negative attitudes and beliefs around antidepressant use in particular, which is typically the default treatment of care. Individuals being less likely to accept antidepressants as a treatment, and there not being enough therapists and counselors around to provide alternative forms of treatment. So the work I do now is really exploring how we can provide what I call non-conventional mental health treatments to individuals in the community. So I work in community health centers, providing alternative forms of care that have an evidence base for improving psychological outcomes. So things like teaching people mindfulness principles, even yoga, other self-care and wellness strategies that may have maybe less stigmatizing than your traditional antidepressant medications and individual therapy and things of that nature.
I think there was a request that we speak up a little bit so back when
Okay.
you can't hear us. But I know I'm loud, so I'm not worried about me. All right, so unbelievable introductions to kind of our individual worlds. Any thoughts at this time? Any questions at this time? I can keep the conversation flowing, but I'd love to make this a larger sort of conversation. Do I see it? No? Please.
I'm very much interested, Dr. Bernez Ziegler, in what you're saying in terms of the alternative practices with self-care and wellness. I would like to know from your perspective, how do you think your clientele, so to speak, take up your self-care and wellness practices, particularly when people tend to think that certain self-care and wellness practices are, sort of quote out there and they're not mainstream, so they're not easily accepted. So how do you think your patients take up your research practices around those topics?
Yeah, so the study that I'm leading right now was really designed to answer exactly that question, whether if these types of interventions like mindfulness, meditation, relaxation, yoga, if they were brought to primarily low-income minority communities, would people actually be willing to engage in them? And what I found overwhelmingly is yes. People are really excited. It's kind of like they've heard about it, but it hasn't been available. There's a large amount of interest. You definitely see reduced levels of stigma. And preliminary data is showing that these interventions are effective in reducing depression, reducing stress, improving functioning, so kind of the ability to get up and go every day, improving a sense of well-being. With that being said, there's still work to do in terms of providing adequate care to people that have a lot of external stressors that are happening. So we see things like childcare, transportation, caring, trauma. I've had multiple people in this study be directly influenced by gun violence, and obviously that makes it difficult to come to treatment. So no matter kind of how good the care is, it's important to still address the environmental challenges that interfere with someone actually being able to get there and participate.
Our clinics, we're doing a lot of training, even of our own staff. I mean, including the physicians, but also across to the front desk staff as well. Kind of what the concept of trauma-informed care is and how this is really changing our approach to patients, particularly here in Chicago. This is such a large deal that I think emergency room, primary care, I mean, all of our offices are dealing with patients who have trauma. So what the concept of, from our side, trauma-informed care is.
Yeah, so I mean, within psychology, it's a whole specialty unto itself. I'll just speak to within kind of the interventions that we deliver in what's called the federally qualified health centers, so community-based health centers that primarily serve uninsured or underinsured individuals. So for example, one of the practices that we teach is like a guided body visualization, and that can be particularly triggering for people that have trauma histories or histories of sexual abuse or violence. So trauma-informed care in that instance would be training the interventionist or the therapist to be sensitive to how that type of treatment would affect someone that has that trauma history. So it may be things like allowing them to not do it, or opening the door, opening their eyes. Really, I think the larger idea is an awareness to assessing trauma histories of people that might be coming into a mental health care setting, and then tailoring the treatment to be sensitive to their experiences.
So building off of that concept, when we're in the emergency room setting and we're dealing with physical trauma, there's obviously a lot of other things going on in the room as well, but how do you see, I mean, there's so many questions to this, how do you see the physical traumas that you're dealing with on a day-to-day basis, I guess really being impacted with the issues of access and other social determinants as far as like education, literacy, things like that. Like trauma in the emergency room, we think of it as just stop the bleeding, but there's a lot more to it than that.
So I'm a child of the South Side, and I was in high school in the 90s when the murder rate was about twice as high as it is now. It's unacceptably high now, and it deservedly gets a ton of attention both locally and nationally. But the reasons behind its spike have very little to do with anything that we can impact in the emergency